Welcome back to this next video in which we are studying headaches. Okay, so we have some final causes of secondary headaches to go over in this video, and the next one up is trigeminal neuralgia. So, trigeminal neuralgia is quite a rare cause of secondary headaches, and really it's going to give rise to facial pain rather than pain in the region of the head that actually surrounds the brain. Although, as we said right at the beginning of the entire thing, a headache includes facial pain. Pain anywhere in the head counts as a headache. So indeed, the facial pain of trigeminal neuralgia does count as a headache, hence why we're discussing it in this video. So, let's start off with a description of what happens in trigeminal neuralgia, and then we'll go on to the pathophysiology underlying it. So, trigeminal neuralgia, firstly then, it's abbreviated down to TN, like so, and what's the epidemiology of it? What is the prevalence of trigeminal neuralgia? Well, I've said that it's a very rare cause of secondary headache, and indeed it is. The prevalence is around 1 in 20,000, so it is rare. If you had 20,000 people, you would expect one of them maybe to suffer from trigeminal neuralgia. So, a description of what actually happens then. What does happen in trigeminal neuralgia? Well, trigeminal neuralgia is episodic headache, so that's the first thing to say, that it's not present all the time. It occurs in episodes, and these episodes give rise to a very, very severe pain. Indeed, trigeminal neuralgia, like when we were discussing cluster headaches, and I said that the pain of a cluster headache is described as one of the worst pains known to man. Again, the pain of trigeminal neuralgia is described as one of the worst pains known to man. So, episodes of severe pain, and it's severe pain in the facial region, so severe facial pain. Okay, so if you suffer from trigeminal neuralgia, you have these episodes of severe facial pain. Let's discuss more. So, usually, this severe facial pain is just going to be in one of the in one side of the face. So it's usually going to be unilateral. However, some people can have bilateral trigeminal neuralgia, which means that the different episodes of this horrendous pain can fluctuate between the different sides. So I'll say that again. Some people have unilateral trigeminal neuralgia, where these episodes of severe facial pain, described as some of the worst pain known to man, will just be on one side of the face. So let's say someone has left-sided trigeminal neuralgia, then they will just get these episodes of severe pain on the left-hand side, somewhere in the facial region. Whereas if you have bilateral trigeminal neuralgia, and you can have bilateral trigeminal neuralgia, it's not, much rarer than the unilateral form, then you will have different episodes of the severe pain on different sides, i.e. One episode might be on the left-hand side and the next episode might be on the right-hand side, but individual episodes are usually just on one side. Even if you have the bilateral form of trigeminal neuralgia, it only means that between different episodes it can swap sides. Okay, so let me just write down a little bit of that. So there are two forms of trigeminal neuralgia. You can have unilateral trigeminal neuralgia, and of course you'd name the trigeminal neuralgia according to which side you have it on. So if you have left-sided trigeminal neuralgia, that would be called left-sided trigeminal neuralgia. Or you can have bilateral trigeminal neuralgia, but usually when you get the episodes of severe pain, they are just on one side. Now, these episodes of severe pain, we've done the site roughly. We've said it's going to be on one side of the face, and it can be in the different regions of the face, but usually it will be in the cheek region, the upper and lower cheek region on one side of the face, but it can extend into the mandible and it can go higher, but in the facial region on one side. So that's the site. Now character. The character is extremely severe, and again, when you have extremely severe pain, it often feels like stabbing. So remember, that was the character of cluster headaches, and indeed again it's the character of trigeminal neuralgia, that it feels as though someone is stabbing you with a knife, or sometimes people with trigeminal neuralgia describe it as though they're getting an electric shock in their face. So, it's an extremely severe pain. Now, another very important thing to know about trigeminal neuralgia is the duration of these episodes, and this is the thing that really seals the fact that someone has got trigeminal neuralgia when you're taking a history and trying to decide what type of headache someone has. The duration of these episodes of pain, it is not long at all. It lasts from a few seconds to a minute, so this is really important that these episodes of severe pain do not last long. So from a few seconds to a minute, so very short episodes of severe pain. Now, these unilateral, severe episodes of facial pain then that feel like stabbing and last for a few seconds to a minute, what are they triggered by? And you can suffer a huge number of these in a day, by the way. What triggers them? Sometimes they'll just be spontaneous. Other times they'll be triggered by touching your face or by wind brushing up against your face. So some sort of activation of the sensory nerves in the facial region can then trigger these episodes of severe facial pain. So I want to put this in here. So it can either be spontaneous, i.e. you can just get it even though nothing was stimulating the area, or it can be triggered by touch, or even just by the faintest touch, like the wind blowing against the face. So triggered by touch. Okay, right. So there is my description, and I'll just summarise what we've seen. So, trigeminal neuralgia, very, very rare disorder. 1 in 20,000 people suffer from this. You can either have unilateral trigeminal neuralgia, where the episodes of pain are always on the same side, or you can have bilateral trigeminal neuralgia, where the episodes of pain are on different sides. The episodes of pain are extremely short. They last from a few seconds to a minute, and of course you can suffer from a huge number of these in a day, because it might be the case that every time you touch your face, that will trigger one of these episodes of severe pain. The pain is absolutely horrendous, so bad that some people describe it as one of the worst pains known to man, and in a single episode it's usually just on one side of the face, because it's usually just involving one of the trigeminal nerves each episode. And the character of it is stabbing, as indeed when you've got really, really severe pain, it tends to feel like stabbing, because that's what the brain interprets really severe pain as. It must be a blunt injury, well, not a blunt injury, a sharp injury, a deep penetrating injury. Okay, right. So that's what happens if you've got trigeminal neuralgia, and it is a horrible, horrible disorder because you're afraid to touch your face because you know what's about to happen. And you try and avoid anything providing stimulation to that region of the face. So, the next question is, of course, why does this occur? What's the pathophysiology behind this? Well, the first thing to say is that this is a form of neuropathic pain. So what does it mean to say that the pain is generated neuropathically? So, neuropathic pain means that it's going to occur because of pathology occurring in the nerves. Neuro means nerves, pathic means pathology. So this is pain that's going to occur because of injury to the trigeminal nerve. Contrast that to all of the different types of headaches that we've discussed previously, where it's not damage to the primary nociceptive afferents that causes this, that causes the pain. Indeed, previously it's always been that we've had the nociceptors being activated and the primary nociceptive afferents firing. Alternatively, of course, we saw the example of cluster headache where it was different from that. In cluster headache, of course, we thought it was direct activation of the second order neurons, but again, that wasn't a form of neuropathic pain. Neuropathic pain, trigeminal neuralgia is our first example of neuropathic pain. Pain that is going to originate from the fact that you have damaged the trigeminal nerves. And if you've got unilateral trigeminal neuralgia, you're going to damage one of the trigeminal nerves. If you've got bilateral trigeminal neuralgia, you're going to have damaged both of your trigeminal nerves. Now, this mechanism that I'm about to tell you, the mechanism of neuropathic pain, firstly, it is a little bit controversial. It's growing in its respect. It is a reasonably established theory now. The second thing to say is that this is not just a theory that works for trigeminal neuralgia. If you damage nerves all over the body, you can get neuropathic pain originating in the portion of the body where primary nociceptive afferents in that damaged nerve supplied. So this mechanism, it applies not just for damaging the trigeminal nerves in trigeminal neuralgia, but also much more broadly, damaging nerves all over the body and then getting neuropathic pain in the region supplied by that body, by that nerve, with nociceptive afferents. Okay, so this is a very important mechanism to understand. So firstly, what I want to discuss before I discuss how damaging the nerves is going to give rise to this, I want to discuss how do you damage the nerves. Let's do this story in chronological order. How do you damage the trigeminal nerves? Well, there are lots of different things that can lead to damage of the trigeminal nerves. However, I'm just going to give you one example of something that can damage the trigeminal nerves. In fact, actually, no, I'll do better than that. I'll give you two examples of things that can damage the trigeminal nerves. And those are two major examples to know about, but of course there are loads of other much rarer things that could then lead to damage of the trigeminal nerves as well. So, I'm going to give you two examples and then we'll see the common pathology of what happens once you've actually damaged the trigeminal nerves. So, one of the major ways that you can damage the trigeminal nerves, and we'll draw a little flow diagram here, so we're starting by discussing how do you actually damage the trigeminal nerves. So one of the major things that can damage the trigeminal nerves is arteries that we have previously discussed, namely the superior cerebellar arteries, the SCAs. Now, let me just remind you about these arteries. Remember, they were branches of the basilar arteries. So I'm just going to draw a little brainstem picture here. So a very basic brainstem picture. So here, this can represent the medulla, like so. So that's the medulla. And then we've got the pons above here. And then I don't think it's necessary for me to put on the midbrain, so we won't. Okay, so two sections of the brainstem shown here. We're imagining we're viewing from above, not from above, from the front. So this is the anterior view, medulla, pons. Now, remember the basilar artery was made from the two vertebral arteries, so thicker pen at the ready. So revising our blood vessels, the extra-axial brain blood vessels that we discussed previously. So those are the two vertebral arteries coming up to the base of the pons and then fusing together to make the basilar artery here. And then at the junction between the pons and the midbrain, remember the basilar artery separates into the two posterior cerebral arteries. And of course, all of this is in the subarachnoid space. Now, before the basilar artery splits into the two posterior cerebral arteries, it gives off the two superior cerebellar arteries, which I'm now putting in there. So those are the superior cerebellar arteries. And remember, these remain in the subarachnoid space. They go under the tentorium cerebelli and therefore on top of the cerebellum, and they will have branches that penetrate through the pia mater that covers the top of the cerebellum and therefore supply the cerebellum with blood once they're intraaxial. Now, these superior cerebellar arteries, whoops, I didn't mean to do that, I thought I had my laser pointer. These superior cerebellar arteries, look where they are. They're going to be running right above where what come in, where the trigeminal nerves come in. So, let me put on my trigeminal nerves. So there's the left trigeminal nerve, and here's the right trigeminal nerve. So these are cranial nerve number 5s here. So, how can the superior cerebellar arteries lead to damage of the trigeminal nerves? Well, if these become ectatic, and that's a fantastic word, a fantastic description. This word, people love this word, ectatic. If an artery becomes ectatic, or not even just an artery, if any tube, whether an artery or a bronchus, which is an airway, if any tube of the body becomes dilated, becomes much bigger than it should be. So if you have a tube that should be like this and it becomes like this, we describe that tube as ectatic, and we call the process of becoming ectatic ectasis, or ectasia, you can also refer to it as, so ectasis or ectasia. When this happens to the bronchi, when it happens to the airways in the lung, we call it bronchiectasis, which means widening of the bronchi, and it's a problem. It causes big problems with breathing the widening of all of the airways inside the lung. However, that's not important now. We're discussing ectatic superior cerebellar arteries. So it can happen to arteries as well as bronchi. So if the superior cerebellar arteries become ectatic, then they can press down on the trigeminal nerves below, and this can damage the trigeminal nerves. So if you get just an ectatic left superior cerebellar artery, you'll just get damage to the left trigeminal nerve. If you get an ectatic right superior cerebellar artery as well, you'll get bilateral damage to the trigeminal nerves, and therefore you'll end up with bilateral trigeminal neuralgia. And this is believed to be one of the major mechanisms in trigeminal neuralgia, an ectatic superior cerebellar artery pressing down on the trigeminal nerve below. And remember what's carried in this. This is after the trigeminal ganglion, this bit. So this is the central processes of the primary sensory efferents coming in. Of course, you'll also have the motor axons coming out that are going to the muscles of mastication, but mainly the central processes of sensory fibres, and the ones that are interesting to us are the nociceptive fibres coming in here. Okay, right. So that's one way you can damage the trigeminal nerves, through the superior cerebellar arteries becoming ectatic and pressing down on the trigeminal nerves. So that's one way. The other way that I will mention is through a very, very horrible disease called multiple sclerosis, MS for short, and I'm sure you've heard of this disease before. It's a horrible, horrible disease. Now, multiple sclerosis, just to tell you a little bit about it, it's an autoimmune disease, so it's when the immune system of the body attacks self-tissue, and it's an autoimmune attack on oligodendrocytes. So the immune system attacks oligodendrocytes, which remember are a glial cell responsible for myelinating axons within the central nervous system. Now, once the central processes of these primary nociceptive and primary sensory afferents running in the trigeminal nerve come into the pons, they will stop being myelinated by Schwann cells and they will start being myelinated by oligodendrocytes, and therefore the central processes of the sensory neurons inside the trigeminal nerve, once they're inside the pons, are susceptible to multiple sclerosis, attacking the oligodendrocytes and then causing demyelination and therefore damage. So multiple sclerosis can also lead to damage of the trigeminal nerves, but it's the damage to the trigeminal nerves once they're inside the pons. Before they're inside the pons, multiple sclerosis cannot touch them because they're myelinated by Schwann cells, and multiple sclerosis does not affect the Schwann cells. So just to write down that little key fact here, multiple sclerosis is an autoimmune attack, an autoimmune disease, and it's against the oligodendrocytes, so on oligodendrocytes. And this causes major neurological problems. It leads to huge amounts of neurological destruction, as oligodendrocytes all over the brain are gradually killed by the immune system, and then neurons end up with no myelination. Okay, so multiple sclerosis can also damage the trigeminal nerves once they've actually entered the pons. So that's another way that you can get damage to the trigeminal nerves. So those are the two ways that I wanted to mention. The ectatic superior cerebellar arteries, that's a classic mechanism for trigeminal neuralgia, and also multiple sclerosis, which is something to be aware of. And very, very rarely, trigeminal neuralgia can be one of the first presentations of multiple sclerosis. It's not usually the first presentation of multiple sclerosis. It's usually a later thing that can occur in multiple sclerosis. And not everyone who gets multiple sclerosis will get trigeminal neuralgia. Okay, so the damage is the first thing that occurs. So that's stage 1 of our flow diagram. In fact, I might even label this up. So that's stage 1, change colour. We now want to go on to stage 2. So how does having this damage to one of the trigeminal nerves, and we'll just study it in the context of one of the trigeminal nerves rather than trying to talk about it bilaterally. Of course, bilaterally it's just occurring in both trigeminal nerves. So if we discuss it for one, you can understand how bilateral trigeminal neuralgia can occur. So let's say we have damage to the left trigeminal nerve here. What happens when you damage a nerve? Well, it leads to particular damage of the myelination, and we understand how multiple sclerosis is indeed going to lead to demyelination of the axons, but even putting physical pressure on a nerve, that, if it's there for a long time, prolonged physical pressure on the nerve will lead to damage of the myelinating cells, and you'll gradually get loss of that myelination, even in the peripheral portions of the trigeminal nerve here, where it's myelinated by Schwann cells. So both of these mechanisms here are going to lead to demyelination, so loss of the myelin sheath from around the axon. So that's stage 2. Demyelination occurs. And again, this is the standard mechanism for neuropathic pain, not just trigeminal neuralgia. Damage, long-term damage, and I should say that this is chronic damage. This is not necessarily just short damage. Okay, it's not enough just to put pressure on this nerve for a few seconds. It needs to be maintained and maintained and maintained, crushing that nerve for a long, long time. So chronic damage to the trigeminal nerves is going to lead to demyelination, whether it's by multiple sclerosis, which of course is a demyelinating disorder of the central nervous system, or whether it's by an ectatic superior cerebellar artery pushing down and then causing death of the Schwann cells in that portion there, and therefore loss of the myelin sheaths. Now, nerve cells do not like losing their myelin sheaths. They do not like it at all. So these central processes of these primary nociceptive afferents, and it's the nociceptive afferents that I'm particularly interested in here because we're trying to explain this painful phenomenon of trigeminal neuralgia, but it will also occur to the other sensory afferents as well, which is why actually the episodes of pain that you get in trigeminal neuralgia can feel extremely odd, because most likely you're not just getting activation of the nociceptive afferents. They're what gives rise to the pain, but you're probably also getting activation of other types of sensory afferents in the same area, and therefore it can feel very, very strange, hence the electric shock sensation of pain. So be aware that this will be occurring to the other types of sensory afferents as well as just the nociceptive ones, but I'm interested in the nociceptive ones. So what happens when you get demyelination of an axon? Aberrant demyelination of an axon that did not want to be demyelinated. Well, the neurons do something very funny that gives rise to this phenomenon of neuropathic pain, and that's that they respond by putting in loads of voltage-gated sodium channels into the portion of the axon that should have been myelinated. So, let's just draw some pictures here. So, here is this axon, and previously it was myelinated, so let's say this is its myelin sheath now, well, its previous myelin sheath, and now this myelin sheath, that I'm drawing very crudely here, is going to have gone because of the damage. So, we're now going to have our axon that is demyelinated. What is the response? The response is to put in loads of voltage-gated sodium channels into the area that has been demyelinated. So, let's go along here. So voltage-gated sodium channels, VGNCs, are going to go up in this region, and you might start to guess potentially what sort of drugs might be helpful for blocking neuropathic pain, which is why I wanted to discuss them in so much detail long ago. So let me try and draw a little bit of this. So just drawing a few of these in, so let's just draw them as rectangles rather than trying to draw them actually looking like channels. So each one of these rectangles is representing a voltage-gated sodium channel, and I'll put them in the other side of the membrane as well. So the response of the neuron to having this portion of the axon that should be myelinated having lost its myelin sheath is to say, let's make loads of voltage-gated sodium channels and stuff them into the membrane in this region. So this means that the membrane ends up with absolutely a ton of voltage-gated sodium channels in it. And we don't really understand what on earth the neuron is trying to achieve through this, but this is what happens. It puts loads of voltage-gated sodium channels into the portion of membrane that has lost its myelin sheath, that has been damaged effectively. Now, what is the effect of putting loads of voltage-gated sodium channels into a membrane? Well, it makes this membrane absolutely hyperreactive, okay? So putting loads of voltage-gated sodium channels into it, the effect on that is that you get this hyperreactive portion of membrane, and I'm trying to work out whether hyperreactive has two R's in or one R. I do apologise if it's only got one R in, but I'm going to put it with two R's. So you get a hyperreactive membrane. So, what do I mean by hyperreactive? Well, let me explain this. So, let me just draw some pictures. So, we'll have an axon here, and let's say it's, and these are really extreme examples. Of course, I can't really show you because we're talking thousands and thousands of tiny little proteins here. But just to make the point really clear, let's have axon 1 over here that has very low density. So this is low density voltage-gated sodium channels. And then let's have axon 2 here that has very high density. So this one's going to be high density voltage-gated sodium channels. So I'll draw lots of them in now. Now, what you have to understand is that the electrical potential difference across the cell membrane, which is usually negative 70 millivolts, it's not maintained at that absolutely continuously. And what I mean by that is if you were to go along this membrane and measure what the electrical potential difference across the cell membrane is everywhere, and you were to watch it over time, so for instance, let's go to this spot and watch what the electrical potential difference across the cell membrane does with time, it would not stay static continuously at negative 70 millivolts. Little fluctuations will occur. Fluctuations in ion movement in the extracellular fluid and ion movement in the intracellular fluid. Remember, the electrical potential extracellularly and intracellularly is controlled by the distribution of charge. Charged particles move around, and therefore the electrical potentials in certain spaces change from time to time. So continuously at different points along the membrane, there are little fluctuations in the electrical potential difference across the cell membrane. Okay, now if you have a membrane here that has a very low density of voltage-gated sodium channels here, then it is very unlikely that a little fluctuation in the electrical potential difference across the cell membrane over here is actually going to lead to the activation of that voltage-gated sodium channel, and therefore it's very unlikely that these little fluctuations in electrical potential difference across the cell membrane, that some of which will be depolarizing, will actually lead to the firing of an action potential. Okay, whereas when you have extremely high density voltage-gated sodium channels in a cell membrane, it's now much more likely that a little fluctuation in the electrical potential difference across the cell membrane will be close enough now to a voltage-gated sodium channel that can then open in response to that electrical fluctuation in the electrical potential difference across the cell membrane. Open, allow sodium in, and then it will cause a positive feedback effect. It will then activate the one next to it and the one next to it, and of course that's what the action potential is all about, a positive feedback of one voltage-gated sodium channel opening and causing other surrounding voltage-gated sodium channels to open, and then it spreads by saltatory conduction. That's what the whole action potential is about. So what I am telling you here is that when you have very low density voltage-gated sodium channels, you're unlikely to get little fluctuations in the electrical potential difference across the cell membrane actually being close enough to a voltage-gated sodium channel to open it, because they're sparse, okay? Whereas when you've got very, very high density, now when you get a fluctuation, it's likely potentially that there will be one close enough to feel that fluctuation and then actually open in response to it because of the depolarization in the electrical potential difference across the cell membrane. So the message here is now that spontaneous little fluctuations in the electrical potential difference across the cell membrane do occur, and when you've got very high density voltage-gated sodium channels, that can now cause the axon to fire. Now, when do these fluctuations in the electrical potential difference across the cell membrane, when are they likely to actually occur? When there are action potentials passing through the nerve. So let me explain this. I've just been saying that I've just hopefully now convinced you that when you have very high density voltage-gated sodium channels in the membrane of this damaged portion of the axon, that this is now going to be able to respond to little fluctuations in the electrical potential difference across the cell membrane in little portions of the membrane now. I'm now going to say, when is this likely to occur? Well, it could occur spontaneously. It could be that you just get a spontaneous fluctuation in the electrical potential difference across the cell membrane that then causes this axon to fire, and that will cause a little bit of pain potentially. However, if you were, for instance, to touch your face, and let's say it's the left trigeminal nerve that's damaged here, if you were to touch your face on the left-hand side, that would now activate primary sensory afferents, okay? And they would be firing action potentials coming through the trigeminal nerve. When neurons fire action potentials along, of course, that will lead to fluctuations in the charged particles in the extracellular fluid in the nerve here, and therefore that is likely to now lead to little fluctuations in the electrical potential difference across the cell membrane of other neurons that are in here, not just the ones that have actually fired. Now previously, when we had low density voltage gated sodium channels and the neurons weren't hyperreactive, that didn't matter and it didn't cause them to then fire action potentials. But now these ones that are hyperreactive in this region, they could now be activated to fire action potentials by other neurons that are alongside them firing action potentials. So, just drawing a little picture of this, so we can make this, if you like, number 5 that I'll put down here. Okay, so let's move what we've got here. Whoops, where's the laser pointer? Let's move this left trigeminal nerve and draw it now bigger here. Okay, so here we go. So, let's draw 2 neurons on here. So let's say that this is the central process of just a sensory neuron, not a pain neuron, one of the other types of general sensory neurons, so it could just be touch. Okay, so this is communicating information about someone touching the left side of your face. And now it's lying alongside the axon of one of the pain ones here, and this pain one has now been damaged by the chronic damage that's been occurring to the left trigeminal nerve, and therefore it has a region of hyperreactivity. So let's say that this region is hyperreactive, and of course also this will have occurred to the touch one as well. All of the axons, well, a huge number of the axons in this trigeminal nerve will have undergone the damage and therefore will have the hyperreactive bit. But to understand where the pain comes from, we just need to be thinking about the pain neurons having this hyperreactive bit. So if you now touch your face, then an action potential can come through here, and of course it won't just be coming in one axon, there'll be loads of axons from these primary sensory afferents from that portion of the face that are now firing action potentials. This will lead to fluctuations in the ions in the extracellular fluid, and therefore it will increase the amount of little fluctuations in the electrical potential difference that is occurring across the cell membrane of this hypersensitive portion of the central process of the pain neuron here. And now, if this is hypersensitive, it can lead to that firing action potentials. Now, when this one fires an action potential, that will lead to more fluctuations in the electrical potential difference across the cell membrane, and therefore it can cause itself to fire another action potential. It can also activate other pain neurons that also have the hypersensitive regions. So what I'm trying to communicate here is that whenever you get any activity occurring in the trigeminal nerve here, it can then activate the hypersensitive regions of the pain neurons that have been damaged here. Okay. So this is what now gives rise to these episodes of severe pain. So let's firstly talk about spontaneous episodes of severe pain. So in a spontaneous episode of severe pain, what will happen then? You've got all of these pain neurons that have been damaged here and now have hypersensitive regions, and they are primary nociceptive afferents from the facial region, of course. Now, if just one of them happens to fire an action potential because little fluctuations have occurred across the cell membrane of the hypersensitive region and have managed to cause it to fire an action potential, then it's going to have a positive feedback effect on other neurons around that also have hypersensitive regions, because once this one fires an action potential, it disturbs the ions in the extracellular fluid now, and therefore others are now more likely to get little disturbances across of the electrical potential difference across the cell membrane, and therefore others are now going to fire action potentials. Remember, pain, severe pain, does not just come from one axon firing a single action potential. You need loads of axons firing action potentials extremely rapidly. So you now get this flux occurring here, and of course this will activate this neuron to fire again and again and again and again, because any sort of flux in the electrical ions in the extracellular fluid around it is likely now to activate the hypersensitive region, and you'll get activation of other pain neurons as well, so you're going to get lots of firing of pain neurons in the trigeminal nerve now, and it does fizzle out eventually, which is why the episode of pain only lasts for a maximum a few minutes. Okay, so that would be what occurs in a spontaneous episode, that one of them is going to spontaneously fire an action potential because of tiny rare fluctuations in the electrical potential difference in tiny bits of the membrane of one of these hypersensitive regions. And then once one has fired an action potential, that causes much more electrical flux of the ions in the extracellular fluid now, and that's going to lead to loads of the other ones firing action potentials as well, because they've got these hypersensitive regions, and it will also lead to the one that originally fired firing again and again and again, and that will give you the severe pain that lasts for this little episode. And it has the weird quality, the electric shock feeling, because you won't just be getting the activation of the pain neurons, but you'll also be getting activation of other types of sensory neurons as well, and it will be felt in one side of the face. Okay, so that's what would happen in a spontaneous episode, and then it's even simpler to explain what would happen if it was triggered by touch, how that would work. Of course, if you touch your skin, that will activate sensory neurons. They will fire action potentials through here, and then that flux caused by the action potentials, the changes in the movements of ions in the extracellular fluid, that will then be activating the hypersensitive regions of the pain neurons and also other sensory neurons, and therefore trigger one of these trigeminal neuralgia episodes. Okay, so there is the pathophysiology, or what is believed to be the pathophysiology underlying trigeminal neuralgia, and again I will stress that all of what we've discussed, damage to the trigeminal nerve in this way leading to this neuropathic pain phenomenon, it can occur in other regions of the body as well. So the same pathophysiology underlies neuropathic pain, episodes of neuropathic pain coming from other regions of the body. We're discussing it, of course, just in the trigeminal region, because that's what we're studying in this video, headaches. Okay, so allow me to summarize the pathophysiology again to make sure we've got it in our heads. So you start by having damage to one of the trigeminal nerves, and we'll just again study unilateral trigeminal neuralgia. If it was bilateral, it would be to both trigeminal nerves. Two major examples of what can damage the trigeminal nerves are ectatic superior cerebellar arteries pressing down on the trigeminal nerves because they run above them, or multiple sclerosis, which is an autoimmune attack on the oligodendrocytes, which would damage the trigeminal nerves once they've actually entered the brain, once they've entered the pons. Okay, when you get this damage, this chronic damage, what it's going to lead to is demyelination of the central processes of these primary sensory afferents coming in the trigeminal nerve. Okay, so you'll get demyelination, and of course the ones that are really important are the primary nociceptive afferent central processes, because they're the ones that are going to actually give rise to the painful sensation. But the demyelination of the other types of sensory fibers probably give rise to the strange quality of the pain in trigeminal neuralgia. When you get demyelination, for reasons that are not well understood, but it makes sense to neurons, they put loads of voltage-gated sodium channels into the membrane that has been demyelinated, and this makes it utterly hyper-responsive. Now, if you get a fluctuation in the electrical potential difference across the cell membrane in just a little region of and then a little portion of membrane in this hyper-responsive portion of membrane, it is likely now that there will be a voltage-gated sodium channel close enough to that depolarization to actually react to it. And once one of them's reacted to it, it then obviously allows loads of sodium ions in, and that will cause the others in a positive feedback manner, saltatory conduction, to then also react to it, and this will generate an action potential. So you get these hyper-reactive areas where the nerve has been damaged. So where you have nerve damage, chronic nerve damage, that area becomes hyper-reactive, and it can spontaneously generate action potentials, and that will occur just because there are spontaneous little fluctuations in the electrical potential difference across the cell membrane at different portions of the membrane, and now when those occur, it's more likely that there will be a voltage-gated sodium channel close enough to act. So one neuron now firing an action potential in the trigeminal nerve, it will then lead to fluctuations in the ions in the extracellular fluid, which will then lead to fluctuations in the electrical potential difference across the cell membranes of the other axons, and then they will fire action potentials as well. And they'll fire action potentials over and over again until it fizzles itself out within a few minutes at the maximum. Within a few seconds to a few minutes, I should say. So that will be a spontaneous episode. If you touch your face, the reason that that can cause an episode is because, of course, that's going to mean action potentials passing through the trigeminal nerve, through this hyper-responsive area, and then that will then lead to flux of the ions in the extracellular fluid, and therefore you're going to get more spontaneous fluctuations in the electrical potential difference across the cell membrane that will therefore lead to action potentials firing in the pain neurons, and therefore another one of these episodes. So hyper-responsive regions of the trigeminal nerves are responsible for trigeminal neuralgia. How do we treat trigeminal neuralgia? The answer is we use use-dependent voltage-gated sodium channel blockers. The drugs that we have discussed previously, thankfully. We know the mechanism of these very well. Remember, these are capable of blocking action potentials from firing at all if they are trying to fire action potentials too rapidly. These neurons in the trigeminal nerve here, these hypersensitive regions of the neurons in the damaged trigeminal nerve, they will be trying to fire action potentials far too rapidly in an episode of trigeminal neuralgia, and therefore they will be completely silenced by a use-dependent voltage-gated sodium channel inhibitor. So let me put this here. So the treatment is use-dependent voltage-gated sodium, and it's not use-dependent voltage-gated sodium channels. Unfortunately, I can't delete that. Well, I can delete it, but I just have to colour over it in black is my way of deleting it. So use-dependent voltage-gated sodium channel inhibitors. So, which use-dependent voltage-gated sodium channel inhibitors? And you might say, well, couldn't we just use any of them? Well, you see, the thing is, you have to also take into account the pharmacokinetics of the drug. It's one thing to consider the pharmacodynamics of the drug, which means what the drug is actually going to do once it's at a site, but you also have to consider the pharmacokinetics of the drug, i.e. which sites in the body does the drug have to get to. So those are actually two very important principles in pharmacology. So I'll just write those incredibly long words down. So two things to consider in pharmacology. Pharmacokinetics, which means where does the drug actually get when you take it in the body, and then pharmacodynamics, which means once the drug is actually in a region of the body, what does it do? We understand the pharmacodynamics of use-dependent voltage-gated sodium channel inhibitors. You now ask me, why can't you just use any old use-dependent voltage-gated sodium channel inhibitor? The answer is they've got different pharmacokinetics. We need one that's actually going to get into the trigeminal nerves, and not all of them do that as well. So the two that are absolutely fantastic for treating trigeminal neuralgia and therefore must get into the trigeminal nerves very well are anti-epileptic drugs by the name of carbamazepine and oxcarbazepine. So carbamazepine is one of the treatments for trigeminal neuralgia, an incredibly effective treatment for trigeminal neuralgia, and one that's very similar to carbamazepine is oxcarbazepine. Again, both of these are anti-epileptic drugs. They can also be used to treat epilepsy, and we understand the reason for that. So AED stands for anti-epileptic drugs. So, the treatment for trigeminal neuralgia is use-dependent voltage-gated sodium channel inhibitors. The ones that we use are not valproate and topiramate, the ones that we saw for the prophylactic treatment of migraine, but instead carbamazepine and oxcarbazepine. These are incredibly effective at treating trigeminal neuralgia. And remember, the reason that not all use-dependent voltage-gated sodium channel inhibitors will work for trigeminal neuralgia lies in pharmacokinetic reasons. You need the drug to get into the trigeminal nerve, and these drugs do indeed do that. They will block neurons from firing action potentials if they are being stimulated to fire action potentials too frequently. And of course, these hyper-responsive regions of pain neurons in the trigeminal nerve that is damaged, they will be trying to fire action potentials far too frequently in an episode of trigeminal neuralgia. Therefore, they'll be completely silenced, but they won't stop any action potentials in neurons that are firing action potentials at a perfectly normal rate, which is why these drugs do not kill you. Okay, so there is our discussion of trigeminal neuralgia complete. We'll have a break here. In the next video, we'll discuss giant cell arteritis.